Ms. Cartwright.
My lady, the gentleman by the witness box is Ben Dyson. Could I ask, please, for him to be sworn?
Please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and
nothing but the truth.
nothing but the truth. Thank you.
Morning. Could you please tell the inquiry your full name?
Benjamin Paul Oakley Dyson.
Mr. Dyson, you've provided 4 witness statements for Module 7, providing essentially the corporate position of the Department of Health and Social Care. Can we firstly identify each of those 4 statements, please? If we can turn first of all to what we're going to call Statement A, INQ 587292. Could I ask, please, for us to go to page 42? Thank you. And it's the first statement dated the 27th of March 2025. And can I ask you to confirm are the contents of that statement true to the best of your knowledge and belief?
Yes.
And is it right to say that essentially this statement gives context as to the structures, the key individuals, and gives an overview chronology?
That's correct.
Thank you. Can we then please move to the second witness statement, which is INQ 587347? Can we please turn to page 85? It's dated the 4th of April of 2025, and are the contents of that statement true to the best of your knowledge and belief?
Yes, they are.
Thank you. And I think this statement principally deals with the scaling up of testing.
That's correct.
Thank you. If we can then move to witness statement C, please, INQ 587346. Could I ask you to turn to page 106, please, within that witness statement? It's dated the 11th of April 2025. And again, is this statement true to the best of your knowledge and belief?
It is.
And I think this statement essentially gives full details of the scaling up of the contact tracing by the department.
And it deals with self-isolation and other matters.
Thank you. So adjunct matters dealing with tracing and isolation, support for isolation.
Yes.
Thank you. And then finally, we can turn please to witness statement D, 587345. Can we turn to page 70, please, where we there see your statement of truth. It's dated the 11th of April 2025. I can ask you to confirm are the contents of that statement true to the best of your knowledge and belief?
Yes, they are.
Thank you. Now, I think, although you're the signatory to these witness statements, it's right, isn't it, that essentially a large volume of individuals have assisted in the preparation of these 4 statements, but you are the person to speak to them?
That's correct.
Thank you. And can we then please deal with you and your background, please? It's right, isn't it, that you personally held 4 roles in relation to the pandemic response? Is it right that you were first director of the reasonable worst case scenario team from March to April of 2020?
Yes.
You then were Director of Policy for NHS Test and Trace from May of 2020 to June of 2021.
That's correct.
You then were Director of Cross-Cutting Policy for NHS Test and Trace from June of 2021 to October of 2021.
Correct.
And then you were Director of Cross-Cutting Policy and Public and Parliamentary Accountability at the UK HSA from October of 2021 when UKHA was established to the March of 2022.
Yes.
Thank you. And I think it's right, isn't it, that since then you returned to the Department of Health and Social Care on the 14th of March of 2022 to take up the post of Director of Prevention Services.
Mm-hmm.
And you are currently Director for the Better Care Fund and Hospital Discharge, a role you've held since December of 2022.
That's all correct, yes.
Thank you. And you're still in that position as at present day. Yeah. Thank you. And Mr. Dyson, can we thank you for the obvious care that's gone into these 4 comprehensive statements, but also you being the person to speak to them. Can we then please start with providing some context in respect of what you say relating to development of testing, please. And I want to go, please, into your statement B, which is then, please, at paragraph 4. So it's 587347. And go to paragraph 12 on page 4, please. That's 587347, page 4, paragraph 12. Now, I'm just going to move through these paragraphs because it's right, isn't it, that you deal with testing for pathogens prior to the pandemic. And if we move then to paragraph 13, but essentially the role of the Department of Health and Social Care, is it correct, pre-pandemic was mainly limited to its oversight of Public Health England?
Yes, the department didn't have a direct role in testing at that point.
And I think that throughout the statement, I think you similarly make the observation that the Department of Health and Social Care didn't, pre-pandemic either, have a role for contact tracing. Is that correct?
Not an operational role.
Again, I think you identify that sat with Public Health England, but also the involvement of directors of public health. Is that correct?
Yes.
But can I then seek your assistance, please? And necessarily our time together today will be focused on specific areas and specific topics. By reference to scaling up of testing, please, and linked to an earlier operation, the Operation Alice. And can I ask, please, for to be displayed INQ 90431. Thank you. And I think you've had an opportunity to consider this document as part of your preparations. And if we move through the report, please, we can see it's a Public Health England report. But if we move, please, through to page 10. Thank you. We can see that action 4 was that the requirement for the development of a MERS-CoV serology assay procedure to include a plan for a process to scale up capacity. And if we can please just continue to move through to Appendix A, I think on page 16, we see that summary of lessons and actions identified. Thank you. And also just to identify the involvement of the Department of Health, please, can we turn to page 18, Appendix C, which is the list of participants. But there's a large number of Department of Health individuals that were part of that exercise. Thank you. And so can we then move back, please, to the recommendation, please, which is on page 10. Thank you. As we can see there, one of the actions from Exercise Alice was to develop a MERS-CoV serology assay to include a plan for a process to scale up capacity. Now, can you assist? Despite this, no plan was put in place to scale up testing. And according to other evidence we have, PHE had never been resourced to scale up testing. Do you accept, or does the department accept that they were aware that there would be need for both planning and capacity to scale up testings as one of the lessons learning from Operation Alice?
Yes, that is clearly one of the lessons as we see here. I think it's worth bearing in mind that this was an exercise about MERS, which doesn't have the same level of infectiousness as COVID-19. So I think it's important not to see this as a blueprint for the scale of testing that we went on to need during the COVID-19 pandemic. And so yes, this is about scaling up capacity, but I don't think there's anything in the report that really envisages the industrial scale level of testing that we did during COVID-19.
Can I just interrupt there? I understand the level that was needed because of COVID-19, but if MERS is not as infectious, yet still Exercise Alice said you needed to scale up testing, surely there's all the more reason that capacity to scale up should have been increased.
I agree. I agree. The recommendation was to include a plan for a process to scale up capacity, as it says here, and as has been reflected in my lady's report on Module 1, we didn't have a plan in place for the industrial scale expansion of capacity that we went on to adopt during the COVID-19 pandemic.
Can I ask you then, leaving aside the industrial scale capacity that was needed, bearing in mind the MERS-CoV was a coronavirus, and Exercise Alice had identified the need for a process to scale up capacity using an assay. Was there any planning done by the Department of Health and Social Care to essentially plan to scale up capacity informed by this exercise?
I don't have any direct knowledge of the work done at the time, so I'm afraid I can't answer the question very directly. What I would say is that at the start of the pandemic, PHE, having developed a coronavirus test, did then expand capacity to some extent, but what was clear, and certainly became clear later on, was that it didn't have the capacity to go beyond that.
Thank you. Can I then ask in terms of asking about the learning or the action from Operation Alice, but were the department aware that there would need to be planning and capacity to scale up testing, but they failed to ensure these were in place by the time of January 2020?
As we've seen, the plan, the exercise report has a clear set of actions and recommendations. I can't say, again, because I wasn't involved at the time, I can't say how far there was awareness within the department, but certainly I would imagine that the emergency preparedness team would have been more than aware of all these recommendations. And I come back to the fact that there were clearly some systems in place to allow what I would call a moderate scaling of capacity, and that's the work that we saw PHE did in the early stage of the pandemic. I would say that there weren't the plans in place to move beyond that.
Thank you. Can I then ask a question again in the context of lack of scale-up of capacity? Could we please display, it's paragraph 104 of a statement of Mr. Hancock. It's 587294. That's 587294, please. And it's paragraph 104, please, at page 31. Thank you. Now, within this paragraph, we can see that Mr. Hancock is detailing his frustration by the lack of scale-up capacity, given Public Health England's early assurances that they had the best system in the world. Now, can you assist? Had the Department of Health and Social Care allocated the development of had they allocated resources to the development of such a system for scaling up testing, or at this stage in February, was it still that it had been left as the responsibility of the Public Health England?
May I just clarify that's a question about testing or tracing?
Well, this is obviously in the context of testing, but also then we'll come on to deal with it separately through the prism of tracing, please.
So, to the best of my knowledge, the department hadn't provided additional resources to allow scaling up of testing. Certainly not to the extent that we saw during the pandemic. No.
Thank you. And then in terms of, again, in the context of the scale up needed of contact tracing, which we'll come on to look at a little bit more together, what was the position of the department in terms of what was there to assist with scaling up on contact tracing?
Again, I can't speak to exactly what the department would have done prior to the pandemic. I think what this statement is telling us is that the PHE certainly had the protocols in place for contact tracing. As it says here, it didn't have the ability to scale up beyond a certain point. Obviously, at the start of the pandemic, the department made clear the government made clear that the resources were not to be an obstacle to further scale up. So, as soon as it became clear that more contact tracing would be needed, resources became available.
Thank you. Can I then please, building on the scaling up of contact tracing, please, can we move into your statement C, so 587346, please, and it's paragraph 40 at page 12, please. Thank you. You detail, and now we're just after the January, in the paragraph before, the contact tracing was considered likely to be more effective in the early stage of the pandemic when the focus was on preventing wider community transmission. And we can see the paper reference there. It noted that contact tracing would no longer be effective and should cease where there was sustained community transmission. And can I ask you, was that the position? Was it linked to the sustained community transmission, or was the reality that there simply wasn't the capacity available for doing the contact tracing? Can we just be clear as to why the contact tracing stopped?
It's worth, I'll come on to the answer to that question. It's just worth emphasising that contact tracing didn't stop entirely. It continued in high-risk settings, most obviously. But as this indicates, the view of, I think, both SAGE and Public Health England at the time was that neither contact tracing nor testing would be effective in when it came to the point of widespread community transmission. But as I say, notwithstanding that, it continued in high-risk settings. You ask whether this was because there weren't the resources for it. That's not my understanding. My understanding is that the position was that other than in those high-risk settings, it wouldn't be effective in controlling widespread transmission once it's covering the whole population.
Thank you. And obviously you've sought clarification that contact tracing did continue in high-risk settings. So can I perhaps use the decision of the 12th of March when the government moved from the delay to the contain phase? And so can you just be clear, because I think you wanted to make some clarification about the fact that contact tracing did still continue in those high-risk settings. And can we just be clear then where you say contact tracing continued after the move from into the contain phase, please?
Yes, that's the case. So Public Health England managed contact tracing largely through its regional health protection teams, who often worked in conjunction with local authority public health teams. And throughout the pandemic, including this early phase, they would have used contact tracing as a way of looking to control and manage outbreaks in settings such as care homes or prisons.
Thank you. Can we then ask a question through the prism of scaling up of testing, please? And can I have displayed, please, the statement of Professor McNally, which is 587245, please? And it's paragraph 11, please. Now, Mr. Dyson, the inquiry's heard some evidence that I know you've identified about the scaling up of testing. Perhaps the context I want to give to this is before we move to the Lighthouse project, there is evidence that the inquiry's heard that other resources were available, including through academic institutions, universities and other research facilities that were offering their laboratories to assist with the scaling up of testing. Now, this is one example of the context. In fact, we've heard from Professor McNally, where he was essentially detailing that the UK universities had the equipment and expertise to help, but it fell on deaf ears. And he's given some evidence about what would have been possible through the University of Birmingham by way of scaling up of testing. And similarly, the inquiries heard from others such as the CRIC as to what was feasible in the early stages of scaling up also. Can you provide any view from the department as to why these offers were not taken up of smaller institutes that could have assisted with the scaling up of testing in the January, February, March and onwards?
Again, I don't have any direct knowledge of this because I wasn't involved at the time. My understanding is that throughout March, Public Health England was very much looking to expand testing. And I think the phrase here about the scrapping of testing for patients is misleading. That there was a decision taken to prioritise testing for hospital patients and indeed for outbreaks in residential settings like care homes. But the aim throughout March, and this intensified from mid-March onwards, but the aim throughout March was to grow testing as quickly as possible. And my understanding, I can't comment on individual offers of help, but my understanding was that at this point Public Health England was working with both commercial and academic partners to do that. So, I appreciate there is frustration here and in other evidence from people who clearly felt they could have helped more. It is entirely possible that if things had been done slightly differently, then that there could have been some more testing at that point. The other thing I'd just emphasise is that this was at a time when it wasn't just laboratory capacity that was the issue. It was also the supplies needed for testing, particularly reagents. So we could easily have been in a position, and I think this was the case throughout March and April, where even if we'd had more diagnostic laboratory capacity available, we wouldn't necessarily have been able to source all the supplies, including reagents, needed to use that capacity.
Thank you. Can we then perhaps give some context to some questions I want to ask you, please, by reference to the devolved nations? Can we first of all deal with the context, please, and can we display your statement A 587292, please? And it's paragraph 83, please, at 22. And I think it's a point you make across the four statements. You say, whilst health and social care policy is largely devolved to the Welsh and Scottish governments and the Northern Ireland Executive, the Department has some reserved policy areas with UK-wide responsibility, including international relations. Public health is a devolved matter, and each of the devolved administrations was responsible for its own testing, contact tracing and self-isolation strategies and operations. This meant that certain arrangements to respond to the pandemic could be, and indeed were, made separately by the devolved administrations. And I think you go on to deal with the work that took place for collaboration. Could I ask you just to give an overview and a summary about what steps had been taken, particularly when there were differences in strategies to try and ensure that there was a understanding of what each of the devolved nations was doing by reference to testing, contact tracing, but also then support for self-isolation?
Certainly. If I may, I'll take those in turn and then make a general point about collaboration. So on testing, although, as the statement says, policy on testing and indeed responsibility for operations was a devolved matter, in practice, all four countries chose to have a UK-wide testing programme that provided essentially the infrastructure, the laboratory capacity, the procurement of tests and so forth. So in practice, although Wales, Scotland and Northern Ireland could have chosen to go a different way, in practice the infrastructure was organised on a UK-wide basis, and that obviously required constant close collaboration across all four countries. On contact tracing, the operations were largely separate, with the exception of the app, which I suspect we may come on to, but the app was, as we know, shared between England and Wales. The other issue on which there was close collaboration was arrangements for cross-border tracing, where you have somebody who's tested positive one side of a border with contacts the other side. So there were protocols in place for that. And then on self-isolation, although again this was a devolved matter, in practice through most of the pandemic, there were some exceptions, but through most of the pandemic the self-isolation rules were the same because they were based on the consistent advice of the four UK chief medical officers. And if I could just add, the Joint Biosecurity Centre, which is possible when they came on to, provided advice across all four nations. And just the final point I'd make is that in addition to what I've described, there were, from memory, if not daily, then at least weekly and very frequent calls between us and the devolved administrations to share insights on everything to do with testing, tracing, self-isolation and other aspects of the pandemic response. I remember, I think it was in June when there were outbreaks in both Leicester and Wrexham, people came together to compare notes and understand how best to respond.
Thank you. Now, you've just referenced the role of the Chief Medical Officer. Can we move to your paragraph 87, please, which is on the next page? Thank you. Obviously, you detail there the role of the Chief Medical Officers, Chief Scientific Advisors and the Deputy Chief Medical Officers, but also the collaboration that took place. And can I ask you, obviously, that statement recognises that as public health has devolved and information, if we looked at paragraph 83, information and experience was widely shared. Can you help? What certain aspects of the different policies across the devolved nations diverge markedly in timing and decisions? And one example that's been explored with a number of witnesses is the Welsh Government's response in respect of testing in respect of asymptomatic. And perhaps, obviously, the UK government announced on the 28th of April 2020 that there would be testing of those that expansion of testing to all staff and residents in care homes in England, whether exhibiting symptoms or not. However, the testing of asymptomatic workers and residents was not adopted in Wales until the 16th of May of 2020. And obviously you yourself identify in your statement that testing for infectious disease is particularly important where infection has non-specific symptoms. And so are you able to assist, and there are other examples of other people's views on how this developed and also the thinking linked to testing of those with no symptoms. Are you able to assist as to whether the scientific advice in relation to asymptomatic testing was captured to ensure it was the same across the four nations in April 2020 and for the remainder of the pandemic? So if something was identified of a significant scientific matter, to ensure then that it was cascaded and dealt with in the same approach across the four nations?
Particularly for that early stage of the pandemic, I'm afraid I don't have any direct insights into the exact nature of how scientific advice was shared across the four nations. Although, as it says here, I'm confident in saying that there was collaboration and coordination, and certainly in all the time that I was involved in test and trace, not only was scientific advice being shared, but we were having regular conversations with colleagues in the devolved administrations to understand how you then marry up that scientific advice with the practicalities of different interventions and the policy implications. And the other thing I'd just say briefly is that it's worth bearing in mind that scientific understanding of asymptomatic transmission, and I think Chris Wormald touches on this in one of his earlier statements, scientific understanding both of asymptomatic transmission and the role that testing could play in relation to asymptomatic transmission evolved gradually over the certainly over the first few months and beyond of the pandemic.
Thank you. Can we please then move for some questions, please, based on your statement B, 587347, and can we start, please, at page 22, just with displaying the table, which is a different way we've looked at the 5 pillars, but I think where you've identified what each of the pillars were and also the organisations responsible for the 5 pillars of the testing strategy from April of 2020. But then having looked at that, because it is going to be relevant to questions I ask you now, please, linked to pillar 1 and 2, can we move, please, to your paragraph 126 at page 27, please? This is under the subheading of testing NHS and social care workers. And you detail within the statement that there were 961,000 COVID-related absences in hospital trusts on the 25th of March 2020, and that the submission recommended that the initial priority needed to be the testing of NHS staff and social care workers, given the importance of health and social care services, particularly for older and vulnerable people. And in fact, there's a submission that's been provided, please, which was the submission from Julia Dudley and Cathy Hall, Approach to Key Worker Prioritisation, which was one of the documents in your pack, dated the 28th of March 2020. Can we turn to that, please, for a moment, which is INQ 546879. That's 546879. Thank you. And can we move forward, please, in respect of this submission to paragraph 8. Sorry, go back. Sorry, it's paragraph 6. Sorry, paragraph 6. Thank you. Thank you. We can see that this paper from the 28th of March identified once we reach more than 1,000 to 2,000 to test today, we'll move into a new mode. The legal position is that devolved administrations have autonomy over testing decisions. As tests are being purchased on a UK-wide basis, the chief medical officers will agree an overall allocation for each nation based on current disease profile and activity profile. The devolved administration will then prioritise key worker testing as best meets their needs. In some cases, and for some groups, 2 or more of the 4 nations may choose to align their prioritisation approaches. Can I ask then, you've obviously identified, if we go back to your witness statement, please, so it's the 587347, and it's please paragraph 135. Thank you. So paragraph 135, please. Page 29. And thank you for your patience, Mr. Dyson, as we move across these documents. You identify that thanks to the successes of implementing pillars 1 and 2 of the testing strategy, eligibility for testing was expanded again on the 28th of April to include anyone over the age of 65 with symptoms, anyone with symptoms whose work could not be done from home, and all social care workers and residents in care homes with or without symptoms. And then can I ask you then, with that having been identified, and also then allocation of testing, having regard to allocation of testing between the 4 nations, was test capacity then increased to the 4 nations in light of the fact that there would then be testing of those without symptoms? So to ensure essentially each of the 4 nations had the appropriate test to do this testing of those without symptoms?
That's a good question. And the first thing to say is that I don't know for sure what the precise arrangements are. As we've seen in one of the other exhibits that you've shown, the agreement was that the chief medical officers across the 4 countries would allocate testing based on both population size and relative need. But I'm afraid I can't say exactly what arrangements were made to factor in asymptomatic testing.
Okay. But are you able to help? Was there someone within the department that had a role for looking at issues such as that?
To look at issues vis-a-vis certainly our testing team. From all the time I worked in Test and Trace, our testing team had a dedicated team responsible for working with the devolved administration. So they would have looked both at the operational aspects of testing and any associated policy issues.
Thank you, and I thank you for your assistance, Mr. Dyson, because certainly with the inquiry I've heard evidence from COVID bereaved that this was a concern, particularly where there was not the standard testing of care home workers, and even in the second wave, for example, we've heard from Hazel Gray that being an issue linked to her parents, and similarly it's an issue that a number of the COVID bereaved statements addressed their concerns. I just wondered whether you could assist with ensuring that essentially the Barnet consequentials to ensure the appropriate testing were increased in line with an identified need for testing of those without symptoms.
As I say, I'm afraid I can't offer more on the detail. I can reaffirm the principle that, as you say, under the Barnet principles, the firm intention was to make sure that there was a fair allocation of testing capacity across the four nations based on both population size and the relative needs of the four countries.
Thank you. Can we then please, staying in your statement B, please move to paragraph 305, please. And that's at page 67, please. In fact, before we go to paragraph 305, can we start, please, at paragraph 297, page 66? And I think perhaps this is an important distinction to make. You tell us by reference to adult social care testing, the department's role in testing for the adult social care sector is referred to at various points in the statement, but essentially you identify that there's a difference by reference to adult social care in the department. And can you perhaps give the clarity? And I think it's linked to where the responsibility for adult social care sits within local authorities. Can you just clarify the position, please?
To clarify the position as regards the department's relationship with the social care sector.
Thank you.
Yes, so the department has overall responsibility for policy in relation to adult social care, but funding for adult social care is a combination, broadly speaking, there are some exceptions to this, but broadly speaking, of funding allocated by what at the time was the Department for Levelling Up, Housing and Communities, and also locally raised revenue. So local authorities also have much greater flexibility, if you like, to decide how to deploy funding and what policies to follow. Notwithstanding that, we may come on to this, the department did play a very active role in working with the adult social care sector throughout the pandemic to support testing amongst other interventions.
Thank you. Can I then please, having identified that, can we move to paragraph 305, which is the creation of a digital portal? Thank you. You refer to the creation of this digital portal to facilitate the rollout of the testing programme in adult social care from the 13th of May 2020 and to allow care home workers to access tests. And I think can you assist, please, whether there was any particular discussion with the devolved nations about how this rollout and testing priorities would operate across the four nations, or was that solely for the devolved administrations?
That would have been a matter for the devolved administrations.
Thank you. Thank you. Can we then please move back to another topic, please, on international cooperation, please? And can we move back into your first statement, please, 587292. It's at page 28, please, of paragraph 113. Thank you. Now, you tell us that throughout the pandemic, the department interacted with other countries and international partners to identify best practice with regard to testing and contact tracing. And then if we can move to the next paragraph, please. You identify that the department also established the Testing and Contact Tracing International Forum to share insight and learning from other countries' testing and contact tracing programmes, and you detailed the attendees there. Can I ask you, because it's identified as representatives from the United Kingdom, would that also include representatives from the devolved administrations?
I don't know whether the devolved administrations did attend some or all of these meetings. What I can say is that at the same time as these international forum meetings were taking place, we were meeting, I suspect, on almost a daily basis with the devolved administration. So if they were not at these meetings and if significant issues had arisen in them, I have no doubt that we would have discussed them with the devolved administrations.
And that's the follow-on. What was the way to cascade knowledge and learning? Is that from what you've just said in the meetings that followed?
Yes, there were multiple forums through which we worked with the devolved nations. My team, which was a policy team, had we had dedicated leads for liaising with counterparts in the devolved administration. So we were regularly discussing policy issues in relation to testing and contact tracing. But there were complementary arrangements for operational cooperation through the testing programme, and as I've mentioned, the Joint Biosecurity Centre was providing advice on the epidemiology and understanding how COVID was spreading to all four nations.
Thank you. Can I then ask you some questions, please, around the development of the app? And perhaps before doing that, can we just contextualise? Mm-hmm. We know that there's reference to the contact tracing app in the May strategy, that it was hoped that it would be available in a few weeks' time. But as it happened, the inquiry had quite a lot of evidence about the development of App 1 and App 2, so I don't want to spend time going over that chronology we've heard. But we know as it happened, it wasn't until the September time that the app was available and I think utilised in England and then Wales. Mm-hmm. That was not till the end of September. So can you assist when it was anticipated that there would be an app that would have a contact tracing function, what impact that delay in it being operational had on the scaling up of contact tracing, please?
To the best of my recollection, it didn't alter the plans we were making for scaling up of what's sometimes called manual contact tracing, although I think manual is a slightly misleading term because even standard contact tracing does rely to some extent on digital support. So essentially during April and May, PHE, together with the department, the Business Services Authority and others, were working to make sure that we had sufficient standard contact tracing capacity, if I can call it that, to deal with the projected number of positive cases and contacts there would be. So from the best of my recollection, I don't think that was affected by the timing of the introduction of the app. And although you're absolutely right that I think at that point in the pandemic there was perhaps greater emphasis being placed upon the importance of the app. Sometimes I think to the exclusion of people thinking about the benefit of standard contact tracing. Certainly we geared up to make sure that we had a standard contact tracing service able to deal with all positive cases and their contacts.
Can we then just deal with this as a topic, please, using your third statement, please, 587346. If we start really with the purpose of contact tracing, paragraph 10, please, on page 4. You tell us that contact tracing is a long-standing public health measure used to identify individuals at risk of having been infected with and manage the spread of a pathogen. This includes both forward and backward contact tracing, with forward tracing forming the primary approach during the pandemic. Now, we can see that principally, I think, a forward contact tracing approach was taken rather than backward contact tracing. Can you assist us to the consideration of that as to the effectiveness, please, of contact tracing by the department?
It's worth saying there was some backward contact tracing undertaken, particularly from, I think, the summer of 2020 onwards. So one of the changes we made within the contact tracing service was to ask people who tested positive not just about who they'd been in contact with in the previous 2 days, but to ask them to think back, I think it was 7 or 10 days, about who they'd come into contact with and provide some clues or indications as to where they may have become infected. And that enabled Public Health England and local authorities to start to identify where there might have been outbreaks associated, so essentially where you have multiple people testing positive in the same setting or in the same area, that can then lead you back to how you manage outbreaks. But it's certainly correct to say that at the start, the big focus was on forward contact tracing as a way of essentially identifying individuals who had come into contact or were thought to have come into contact with the person who's just tested positive, and then to advise them to self-isolate.
And can I ask you, you detail within the witness statement essentially the process of the scale-up and how then the Public Health England teams and then the involvement latterly of the local authority directors of public health. But certainly one of the issues and themes in the inquiry is the underutilisation of the local contact tracing and the skills of the directors of public health. I think you've just identified how there was some backward contact tracing that started in the summer of 2020. Do you identify that link as to when the contained framework was established in the July of 2020 and essentially looking to use more of those local resources by the directors of public health?
So there are a number of issues here. I mean, first off, can I say I think it's a critical piece of learning from the pandemic that we understand as far as we can how you get the best balance between local and national. And certainly in hindsight, there are things which I think a number of us wish we'd done slightly sooner to strengthen the local element of that relationship. It's also worth saying that and we've touched a bit on this already, that from the start, there was certainly local authority involvement in the more complex cases. So even before the introduction of test and trace, where there was an outbreak in a care home or a prison, it would very often be the public health protection team, that's a regional team, working with local authorities to take appropriate action in that setting. So there'd been an element of local contact tracing from the start. And indeed, when we established the test and trace service on the 28th of May, it was built into the model from the start that you have essentially a three-tier system. And the first tier is where the person who's tested positive is from, say, somebody who works in a care home or a school or a prison, and straight away those cases would be referred to health protection teams who would then often work with local authorities. So that's context in terms of what was done from the start. The big change from around June, July onwards was to start to look at people who tested positive and whose details had therefore come into the contact tracing system, and where the central tracing teams were unable to reach them. So the central tracing teams would have routinely emailed, texted, and then where they didn't get a response, they would seek to phone them. But we were finding that some people were either not engaging or were engaging later than was ideal. And so the approach taken at that time was to start to ask local authorities to do the tracing of positive cases for those who the central service had been unable to reach. And I think that was an important step in if you like, harnessing what local authorities could bring to contact tracing with the greater efficiency that you could get from doing more straightforward contact tracing on a national basis.
And can I ask you, in terms of the central service and the building up of that from scratch, I've described it as call centre contact tracers, albeit they may have been operating virtually as a call centre. But who in the department had an input as to the numbers or that centralised model initially before the skills of the local authorities and local contact tracing was identified as really being the preeminent skill? Can you help us to who identified the numbers that were needed for that central contact tracing, or who thought a centralised approach was the best way to go initially?
So again, I think there are a number of questions caught up in that. In terms of who thought the centralised system was the way to go, ultimately that was a ministerial decision, but it was based on the, as I recall, the firm recommendations of both Public Health England and the team within the department that was responsible for what became Test and Trace. It was called I think the Test, Trace and Certify programme at the time. So the team in the department and Public Health England, supported by the NHS Business Services Authority, had identified that the most efficient and effective way of scaling up contact tracing at the start would be through that three-tier model. The first being the local for the high-risk cases and the more complex contact tracing. The second element being health professionals, doctors, nurses and other health professionals that were brought in to act as people who interviewed the person who tested positive. And then finally, the third tier was the contact tracers who essentially phoned people who were identified as contacts.
Can I ask you, would you agree that if the local level infrastructure of contact tracing was utilised from the outset, it would have increased test and trace capacity?
So certainly it would have been advantageous, there is no doubt about this, it would have been advantageous if early on it had been possible to adopt the blended tracing model that we did. I think it's still the department's view that where you have what I'm going to call straightforward cases, and essentially by that I mean somebody who's tested positive who is ready to engage, ready to share information about their contacts, and then it's relatively straightforward to get in touch with those contacts and pass on advice. For those more straightforward forms of contact tracing, I think the department's view still is that there are obvious efficiencies in doing that on a national basis. But yes, I agree that particularly where there are people who are perhaps either more reluctant to engage with a national service or are taking time to engage with a national service, it would have been beneficial to have the local tracing element in place sooner.
Thank you. And then can I ask you, why did it take until July for this to be established, and only then I think initially on a pilot level in certain local authorities? I
mean, but partly for the obvious reason, and this is I think another key lesson, that we didn't have plans in place before the pandemic, and certainly I my personal view, my personal view is that should be a key learning for the future, that you plan in advance for the type of local national blend that you're likely to need. I think the other thing I'd draw out is that there may have been a degree of optimism bias, if I can call it that, in terms of how successfully the national service would be able to get in touch with people and get in touch with them quickly. It did do that for the majority, indeed the great majority, for most of the pandemic, of people who tested positive. But I don't think anybody had quite anticipated that there would be a sizable minority of people who were either not engaging or really taking time to come back and engage with the National Tracing Service.
Thank you. Now, I'm not going to go through the aspect of your statement that deals with the local outbreak management plans and essentially the allocation in June of 2020 of the 300 million to local authorities to develop local outbreak management plans. But can I ask you, was lack of resources also an inhibiting factor to the establishment of a localised system of contact tracing?
As I say, I don't think it was ever considered, and I think it's still the department's view, that it would be unwise to consider a system where you put all of contact tracing responsibility with local authorities. So that model would certainly not have been possible, but nor do I think would it have been desirable. it is certainly the case that as we started to roll out local tracing partnerships, there were times when local authorities were unable to deal with the volume of cases that were being referred to them, and we had to adopt a very flexible model whereby we could adjust the thresholds that you use to determine which cases a local authority takes on and which cases the National Service continues to operate. So yes, it's possible that certainly at the margins additional resources would have been helpful. It's worth emphasising, though, that the money allocated to local authorities under the Contained Outbreak Management Fund, which you referred to, was definitely intended to give them as much flexibility as they needed in deciding how best to use that resource to tailor testing, tracing and support for self-isolation to the needs of local communities.
Thank you. Can I then ask you on the app, please, in your statement, please, at paragraph 127. So this is in the 587346 statement, please. That's 587346 statement C is paragraph 127. It's just a question on the use of the contact tracing app. Mm-hmm. And obviously you give the detail within the statement about that development and rollout. But if we could go, though, please, to 587346 at paragraph 127. Thank you. You deal there with interoperability with the devolved administrations was discussed at an early stage. Wales chose to join with England in adopting the NHS COVID-19 app, while Scotland chose to develop its own contact tracing app. Northern Ireland joined with the Republic of Ireland in adopting a test and trace application. The NHS COVID-19 app was interoperable with the Northern Irish Stop COVID Northern Ireland app because it was also based on the Google Apple system and became interoperable with the Protect Scotland app in November of 2020. Are you able to assist as to the liaison that took place with the Welsh Government as to why they stuck with the NHS COVID-19 app and didn't develop their own contact tracing app?
I didn't have any direct involvement on this particular issue, so I can't. I'm not sure I can add much in terms of the specific conversations that took place with devolved administrations, but I'd reiterate what I think both Matthew Gould and Simon Thompson have said in previous sessions about the regular contact we had with all four nations throughout the development of App 1 and App 2.
Thank you. And if we could go back a page to your paragraph 125. Thank you. You deal there with the analysis from the NHS COVID app by reference to the Nature article of May of 2021. And so essentially you identify the positive things that the app that was rolled out and used in England and Wales had by reference to preventing 1 million cases, 44,000 hospitalisations and saved 9,600 lives. But can I ask as to whether you can assist in identifying the analysis of the data from the app, whether you can help with the trend that was also picked up in that Nature article, which is, please, can we go to that very briefly, 475153, and it's internal page 27, please, 475153. Thank you. And could the map be expanded? So obviously there's been some review of the article, but obviously no reference to this universal trend of low uptake across Wales. Has that been spotted at any point by the department, and can you cast any light on why there appears to be the low uptake of the 16 to 20% or even lower in one area almost universally across Wales, please?
So on the first question, I'm afraid I can't be absolutely sure. I do know that as a test and trace service within the department, we were very alert to the what we knew to be the risks of different levels of uptake in different communities. But I'm afraid I don't recall any specific discussions about this strikingly low uptake in Wales. And sorry, the second part of the question was
Whether there been any analysis of
whether
it?
there's been any analysis. I don't know, I'm afraid.
Okay, thank you.
Should just say, I think, was it Mr Drakeford or somebody questioned the accuracy of the map?
Okay, can I ask you, bear in mind, the department has relied upon the data to identify those positive things that the app had identified. Has the department identified any issue with the data that fed into this Nature article?
Not that I'm aware of, but I'm not familiar with any work that's been conducted since the pandemic, which could have touched on that.
Thank you. Could I then please move on to a separate topic, please, which is support for isolation and then the enforcement of isolation. And to contextualise the question, can I ask you, if we look in your statement D, please, 587345, and can we go to paragraph 109 at page 35 of statement D, please? Thank you. Thank you. You deal with the rollout of the contact tracing, and also at paragraph 110 that the department recognised that for some people self-isolation was likely to have an impact in respect of loss of income, concerned about job security, loneliness. And I think if we look at paragraph 108 also, please, I think it had already been identified by the department in May of 2020, the inequalities that self-isolation would cause to individuals. And can I first of all capture when the department had identified that there was going to be almost a disproportionate impact of isolation on many?
My recollection is that this would have been considered throughout April and May. So certainly when I was involved in both April and May, we were thinking about the impact of that would arise once we are testing on a much more widespread basis and contact tracing on a widespread basis, and therefore asking thousands of people to self-isolate.
Thank you. And then can we move forward? It's a paragraph that's within reflections and lessons learning. It's paragraph 203, please, at page 65. And just on this theme of isolation, support for isolation, and then the enforcement, you say this: some of the individuals consulted in the development of the statement reflected that for any future health threat, it will be important to consider carefully the balance of potential benefits and risks in making rules on self-isolation or other public health measures legally enforceable, taking account on the one hand the value of reinforcing the critical importance of these rules, and on the other hand the potential impact on uptake of testing and engagement with contact tracing and the challenges of enforceability. Some individuals consulted in the development of this statement also reflected on the potential advantages, subject to public health advice and behavioural insights, of encouraging and enabling individuals to take a greater personal role in giving information to their close contacts to complement the role of contact tracing teams, and of exploring how to strike the right balance in terms of the detail and specificity of self-isolation rules, bearing in mind the possibility that what are perceived as overly restrictive rules could limit adherence. This requires understanding both the science behind how any future pandemics operate and behavioural insights into how people are likely to respond to rules or guidance, and applying that knowledge to implement tailored measures specific to the threats. These reflections are not departmental policy, but have been included in the statements so that lessons learned by individuals who worked on testing, contact tracing and self-isolation policy during the pandemic can be documented. And so obviously that's obviously a clear view that is not attributed to any one individual, but did you have an input in that particular paragraph, and is that expressing your own personal views, Mr. Dyson?
It expresses a number of views, and it's probably worth saying that these reflect views of people who were involved in the Department of Health and in Test and Trace. I suspect you would get somewhat different views if you spoke to people in other parts of government, but certainly this reflects, I think, both my views and a number of my colleagues' views at the time.
Now, you deal with the history around the development of the self-isolation payment that came in at the end of September alongside the legal enforcement of isolation. And I think, in fact, you led on the policy for isolation support payments. And we're going to hear some evidence, I think, from Baroness Harding on Thursday that identifies a pitch that was made to make the scheme equivalent to the jury service payment, where essentially you could claim £64.95 per day for the 10 days. Can I ask you, just by way of overview, can you help us to why it took, when it was identified that people need financial support to isolate, and that certainly seemed to have been identified as early as May, if not earlier, why it took to almost the end of September before there was a scheme, leaving aside the statutory sick pay, that provided a scheme for financial support for isolation?
Yeah. You've said leave aside statutory sick pay, so I'll only touch on that.
It is, and it's more this specific fund that gave support to individuals to isolate.
The reason why I think both statutory sick pay and other benefits is relevant in this context, because certainly the view of Treasury at the time was that the combination of statutory sick pay and the eligibility that some people on low incomes would have through other benefits, income support, housing benefit and so forth, coupled with the furlough scheme, provided in their view a reasonable and proportionate response. That was not our view within the department and with Test and Trace. And throughout June, July and August, we worked with Treasury colleagues and others to seek to identify some different possible ways of specifically opening up financial support to, or more generous financial support to, people on low incomes. And the reason those weren't initially successful was, I think, primarily a view within Treasury, amongst Treasury ministers, that first off, they were unconvinced that this would have the impact we claimed it would. We felt this was very important, particularly in getting people to come forward for testing in the first place, where we knew that the financial disadvantages they would face if they tested positive and then were then asked to self-isolate were a barrier. So it's partly they felt we weren't providing firm enough evidence that it would have a positive impact, and second, they were concerned from memory that there are difficulties in providing financial support when you can't verify that people are then self-isolating. People could be paid but not self-isolate.
Thank you. Can I ask you, having looked at what you say about the May of 2020, the inquiry also has evidence from Professor McKee that details that isolation is a key element of a pandemic control strategy and was a weak link in the United Kingdom, with a key element being financial vulnerability due to comparatively low statutory sick pay, about 29%, and inadequate emergency payments, leaving many without adequate financial protection. Would you agree that by May of 2020 there was a recognition within the department that there was lack of adherence to self-isolation advice, which undermined the efficacy of the Test and Trace programme?
This is an important point, and I haven't got Professor McKee's statement in front of me, but from memory he refers to reported evidence that only 20% of people were self-isolating. And the point I just want to emphasise is that was a statistic based on people who had symptoms of COVID. And sadly, through most of the pandemic, certainly at this time, I think fewer than 30% of people with symptoms were getting tested. The surveys that we were doing within Test and Trace, and these were borne out later by studies done by the Office for National Statistics, show that if you did come forward for a test and you tested positive, or if you were identified by Test and Trace as a contact, you were likely to self-isolate. So very, very different results for people with symptoms versus confirmed cases and their contacts. And what we also found from our surveys and from the ONS's surveys was that even if some people said that they weren't following the strict letter of the rules, the great majority reported that they avoided contact with other people. So they might leave the house to go for a walk, but they were not going to work, they were not going to bars or restaurants. So I think there's a crucial distinction between self-isolation for people with symptoms and self-isolation for people who've tested positive. But I think that reinforces what was then our view that given one of the critical elements of a successful testing and tracing service is people's willingness to come forward for testing in the first place. If you know that the financial consequences of testing positive and then self-isolating might be a deterrent, then that is certainly something we felt we needed to test. And that was borne out by pretty much all our conversations with local authority directors of public health. Again, they couldn't provide the hard and fast evidence that Treasury colleagues were looking for, but I think it's fair to say that every local authority director of public health we spoke to said this is a big issue, particularly in more disadvantaged communities.
Now, having asked you to put aside statutory sick pay, can I ask you, do you agree that the lack of statutory sick pay infrastructure around the test and trace system and inadequate emergency payments compared to other countries undermine the test and trace system's efficacy?
We don't have, I think it's important to emphasise, we still don't have good, hard and fast evidence on this. I still don't think we know how far either the level of SSP, which I think was about £94-95 at the time per week. We don't know how far the level of SSP or eligibility for SSP was a factor, so we can't quantify it. But certainly, as I say, our concern and that of local authority directors of public health were, first off, that the level of statutory sick pay was unlikely to be enough to encourage everybody who needed to self-isolate, and second, that there were key groups like people on lower incomes, the self-employed, people on 0 hours contracts and so forth who wouldn't benefit from it.
Thank you. Can I then please, still in your statement D, please, 587345, turn to your page 112, please. Sorry, paragraph 112, page 36. And it details that self-isolation equality issues identified the department in its May and September 2020 equality impact assessments and the mitigations which were put in place to address them. And also references then the equality impact assessments shared with ministers on the 21st of May of 2020. Thank you. Now, can I ask you, because the inquiry has an expert report of Professor Matchin, and the view taken by Professor Matchin is that the equality impact assessment completed in England was inadequate, and the evidence it presents is inconsistent with established knowledge on the disproportionate impact of self-isolation on certain groups in society. And the report continues, a clear rationale has not been provided for why there is no specific impact on any group in society. And I think you've had an opportunity just to review that paragraph of Professor Matchin's report. Can you assist what steps were taken by the department to ensure that vulnerable communities, including ethnic minority groups, were properly informed of and supported in accessing support for self-isolation?
So again, I agree. This is a critical issue, and from the start, and I'm not saying we always got this right, by the way, but from the start, the department and the test and trace service were looking to understand how we could make sure that you have a combination, essentially, of three things. One is good comms and engagement to make sure that people understand not just what the rules or guidance say, but also why it's important to self-isolate. So to provide the motivation to do so when you're asked. The second is the practical, social, and emotional support, and the third, which we've touched on already, is the financial support. And throughout the work we did, we were trying to get a balanced package across all those three elements. That's reflected in part in the work that we did with local authorities, starting with the Contain framework, which you've mentioned, and the funding given to local authorities under the Contain Outbreak Management Fund, which was designed in part to enable them to communicate and engage with different communities, working with voluntary organisations, faith groups, community champions and so forth, but was also designed to enable them to offer or partner with the voluntary sector and others to either offer or signpost people towards support. What we found when we were looking at this in the autumn of 2020 was that although there were some excellent examples of what local authorities had done, there was also some inconsistency, and that led to the decision to develop a framework governing practical, social and emotional support, and to give additional funding, which I think began in January of 2021, to local authorities to enable them to go further in either offering or mobilising offers of practical support for people self-isolating. But having said all that, I think the main point I would make is that I think lots of us working on Test and Trace at the time would, with hindsight, say that we wish it had been possible to do more sooner. And I think this is a critical element of preparedness for future pandemics. However technically good your testing and tracing systems, they're only as good as the willingness of people the willingness and the ability of people across different communities to use them.
Thank you.
Well, sorry to interrupt. What would you have done sooner? You've been through one or two things. Is it? Do you have a list of what you and your colleagues feel could have been done sooner?
I can give some examples of that. I've mentioned the framework that we developed, which was it was just a framework, but all the local authorities we worked with said that they found it a helpful framework for understanding the different elements of practical, social and emotional support you should offer, and giving additional targeted funding to help with mobilising that support. We did that in January 2021, I think. I wish we'd done it sooner. Similarly, it was about that time that we introduced the medicines delivery scheme for people self-isolating, which had already been in place for people who were shielding, but it wasn't until 2021 that we extended that to people self-isolating. And again, with the benefit of hindsight, I wish we'd done that sooner. But more broad, I think the broader thing I would say is, and I believe there's some evidence from UKHSA on this. This is work that UKHSA have done since the pandemic. But what they found, and I hope this is a fair characterisation of their work, is that some of the things we did to communicate and engage better worked. Some worked less well. So it was quite mixed. And the things that work best is where you are working through local groups. It may seem a very obvious point, but having local authority directors of public health and their team able to work with those voluntary organisations, faith groups, community champions and so forth is probably the most important thing when it comes to cutting through and making sure that people not only have got the support they need, but also that they understand the importance of engaging with testing, self-isolation and so forth. And I think a critical part of future preparedness for pandemics is having the protocols in place from the start to understand how you essentially at the same time within the first 100 days that you are building up your testing and tracing capacity, within those first 100 days, how are you working with local communities to build trust and willingness to be part of the response.
Thank you. And finally, on lessons learned and recommendations, please, Mr. Dyson. A good part of Witness Statement D, at pages 50 to 69, deals with lessons learned, reflections and recommendations. But can I ask you, in respect of data. If we can just display page 64, please. Sorry, 62. Diagnostics and data are crucial in a pandemic response. But can I ask you specifically, first of all, and if there's time, a follow-up question, how did the department's shortcomings in respect of the collection and evaluation of data exacerbate the inequalities faced by ethnic minority healthcare workers and communities in relation to test, trace, ice policies, please?
So first to say that again, data sharing is important and was recognised as such from a very early stage. So there was some features of the way that we had to establish initial services at huge pace and at scale that meant that the right data sharing arrangements weren't in place at the start. But from, I think, May onwards, it was an explicit role of the Joint Biosecurity Centre within Test and Trace to work with local authorities to improve data sharing. But I'm very aware that there've been a number of criticisms about the speed at which that happened and the scale at which it happened. What I can't do is, I think it'd be, I'm not sure that anybody could do this, is to pinpoint the quantitative difference that made to ask the what if this data had been available sooner. Can we quantify the impact that would have? I suspect that would be very difficult, and I certainly can't provide an answer on that.
Thank you. My lady, that's my time up. And so there are core participant questions from COVID Brief Members for Justice Cymru.
Thank you. Ms Parsons, I don't know whether Ms Cartwright's left you. I think she may have pinched at least one of your questions.
She has, my lady. In fact, both our permitted questions have been covered by this witness, but I wondered whether I might be able to follow up just briefly on the first of those topics, that's scientific advice on asymptomatic transmission.
Certainly.
Thank you. Good morning, Mr Dyson. I ask questions on behalf of the COVID-19 Bereaved Families for Justice Cymru. Your statement describes good levels of coordination and collaboration between the scientific communities of the four nations. I want to ask you about scientific advice on asymptomatic transmission, and I do appreciate the limitations that you've given in your evidence this morning on what you can help us with. But the inquiry heard last week from Mr Hancock that he received advice, scientific advice, on the 14th of April 2020, and that advice marked a major change of approach. In short, it meant that asymptomatic transmission became a baseline assumption for policy making and decision making. Can you help at all with whether that scientific advice would have been shared among the four nations?
I'm afraid I can't. I'd only refer back to what I said before, that certainly the principle throughout the pandemic, I've no reason to suppose it was different at the time, the principle was to work very closely across the four countries in relation to both scientific advice and public health advice. But I'm afraid I can't shed further light on what specific information was shared at that point in relation to asymptomatic testing.
Seems likely, doesn't it?
It does. Thank you. Thank you, Mr Dyson.
Well, given how much the CMOs were working closely together.
Yes, I'm perhaps being overcautious in not speculating about things that I don't know. I would find it very surprising, but I've been warned not to speculate too much about things. I can't be sure.
Well, thank you very much indeed for your help, Mr Dyson, and for providing the reflections from you and some of your colleagues. It would be extremely helpful. And I repeat what I've said many times to other people from government departments, particularly the DHSC. I am so acutely aware of the burden that we've been placing on you and your colleagues. So thank you very much for what you've done and your colleagues have done to help us.
Thank you.
Very well. I shall take the break now and return at 12:10.
Thank you.
The next witness, my lady, is Dame Rain, CBE.
Take the Bible in your right hand and please repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the
the
whole truth,
whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Take a seat.
Dame June, thank you for coming back to help us.
Could you state your full name, please?
June Munro Rain.
Now, Dame Rain, you've provided...
Dame June, I think, sorry.
Dame June, you've provided a witness statement dated the 2nd of April 2025. We can see the date there on the top right and on the final page as well. Have you had an opportunity to familiarise yourself with your witness statement recently?
Yes, I have.
I'm very grateful. Can you confirm that the content of that statement are true?
I can confirm that.
Now, this is a corporate witness statement on behalf of the Medicines and Healthcare Products Regulatory Agency. I'm going to refer to it as the agency, meaning effectively that you've had the input and the benefit of a number of other individuals in preparing this witness statement. Is that right?
I have, very much so.
And this is your Module 7 witness statement, I believe your fourth to the inquiry. You've previously provided written evidence in Module 3, Module 4 and Module 5. And you've also given evidence in Module 4, so you'll be certainly familiar with the process. Could I just invite and remind you to keep your voice up and to speak into the microphone, please? Now, you were the chief executive of the agency until the 31st of March of this year, is that right?
I was.
Now, at paragraphs 5 to 10 of your statement, you give details of your professional background, and your statement will be published, as you know, on the website so that the public will have the full context of your witness statement and your professional background. So I hope that you will forgive me for not repeating it now. With regards to your role and responsibilities as Chief Executive of the agency, you say at paragraph 5 of your statement, page 2, that you were accountable to health ministers for ensuring that the agency took all possible steps to ensure that medicines, medical devices and blood products for transfusion meet appropriate standards of safety, quality, effectiveness and performance. Is that correct?
That's correct.
And the just in terms of the regulator, the agency, it's an executive agency of the Department of Health and Social Care, is that correct?
It is.
And it takes decisions on behalf of the Secretary of State, is that so?
It does.
And the function of the agency is wide, and your statement touches upon various aspects of it. For the purposes of why you're here today to give evidence with regards to Module 7, it's with respect to test, trace and isolate. As succinctly as possible, could you please summarise for us the role that the agency played with regard to testing of COVID-19?
Well, thank you. The agency played the role, as it does with all medical devices, from clinical investigations, these are proposals to undertake studies, right through to looking at surveillance. The important point the agency undertook during the pandemic was to be flexible and adaptable, and one of the key tools is the exceptional use authorisation when there is no available product and a medical need arises. Part of the flexibility and adaptability was also to use the very extensive scientific resource the agency has to produce target product profiles to drive up industry scientific endeavour to produce the best possible products to benefit the public's health. And it's very good to know that those target product profiles, including for self-testing of asymptomatic people, had benefits worldwide. So a flexible and adaptable agency focusing on the access safely to innovative diagnostics.
And so with regard to diagnostics that were used during the course of the pandemic that we're concerned with, LFD tests and PCR tests. What was the role of the agency with regard to those two tests?
The lateral flow device tests and the PCR, the polymerized chain reaction tests, are both medical devices. And as just mentioned, we would be concerned with any clinical investigations that were to be conducted, and we would also conduct surveillance. And in respect of our tool that we used extensively in the pandemic, exceptional use authorisations, we used that for those particular types of diagnostics.
Now, in your witness statement, I needn't take you to it. You say that the agency didn't approve testing kits, but it regulated them. Could you perhaps explain the distinction, please?
The generality is that a medical device, and that includes a diagnostic like a lateral flow test, receives a conformity assessment mark either from a European notified body or from an approved body, as now we can issue a UK CA mark. But as I've stressed, during the pandemic, we were able to use the power to exempt companies from meeting those standards and requirements by issuing an exceptional use authorisation. So I hope I've helped with the distinction there, that the generality is that we do not approve, but in this case we were capable of making judgments about the circumstances and the data needed to exempt a product from CE marking or UK CA marking.
And in fact, that there were 17 occasions when the use of exceptional authorisations was made. Is that right?
That's right.
Now, there are three topics, time permitting, that I'd like to explore with you. The first is wastewater testing. The second is issues with those diagnostic tests that we've outlined. And thirdly, recommendations for the future. So starting with wastewater testing, please. The agency played a role in wastewater testing, is that right?
That's correct, but building on experience as a WHO collaborating centre for polio, where there's a long-established monitoring role looking for any fragments of the polio virus that might hint that this was coming back, which is clearly something our immunisation policy colleagues would wish to prevent. There was evidence in the pandemic that the SARS-CoV-2 virus particles, the ribonucleic acid, could be picked up in a similar way. And so what our scientists did was to look back to ask the question, did what we might pick up in the wastewater, the sewage, mirror clinical infections?
Just coming to that then, you set it out in your witness statement, page 26, paragraph 82, that by testing wastewater samples from a North London sewage site serving 4 million people retrospectively, the agency was able to ascertain that on the 11th of February 2020, so 3 days before the first case of COVID-19 was reported in the sewage plant catchment area, low levels of SARS-CoV-2 viral ribonucleic acid was present, so RNA was present. Is that right?
That's correct. And further samples showed an increasing concentration as COVID took hold in that area. And more importantly, my ladies, the agency scientists were able to pick up variants when the genetic sequence changes. So overall, an important piece of work, although, as Council is saying, retrospective at that stage.
Can you help us with whether it was possible to undertake the testing of wastewater samples prior to July 2020?
It would have been possible, particularly as the technology and the research team had already used that methodology, that kind of research for polio. And it was important that that continued. The discovery that SARS-CoV-2 fragments had been detected in other countries was what triggered the piece of research we're talking about.
So do I understand it then that the reason why it was done in July 2020 as opposed to earlier was because of what the agency was viewing happening overseas?
Yes.
And that prompted then for the retrospective investigation. Can you help us then, if that information had been known in real time, sort of say, for example, in March 2020, how could that have been used in responding to the threat posed by the virus in those early stages?
From what we know now, it could have been an early warning, and it could have been systematically used to look for variants as they appeared well before, appreciably before, clinical cases then were tested. And it's a matter of thinking that this could be done UK-wide and even internationally to help us be on the front foot and look for these early warnings. So if I continue a little bit, this is a subject we're looking at carefully at the moment. You find what you look for. Should we be expanding the range of kinds of viruses that wastewater testing could look for?
And just on that point then, can you help us understand what are the limitations to wastewater testing?
At the moment, we have a small team, our polio team, whose names are on the paper together with Public Health England. The reliance on grant funding, the funding from the Coalition of Epidemic Preparedness Innovations has been invaluable. And the need for the kind of international network, we might come to this, considering the World Health Organization is now looking to build alignment internationally. So there are several things: the science, capability and capacity, the funding, and the design of a system that could be switched on and scaled up as needed.
Given, so basically, are you talking about a surveillance going on the whole time?
In a
As well as
defined set of viruses or other pathogenic organisms.
So given that viruses change in their nature, forgive me, I'm no scientist, given they change their nature, how might you detect a novel virus like COVID-19 was if you were doing this kind, or would you only start it once you knew something more about the new virus?
The COVID-19 was actually one of the viruses that the scientists in our laboratories had actually been ready to look for because of the experience with SARS and MERS. As you say, my lady, the challenge is to expect the unexpected, but I think it's quite clear that there could be a hit list or a panel of multiple pathogens that perhaps with an international agreement could be what was systematically looked for.
And if you're talking about, as ever, everything comes back to resources, what sort of size of cost are we talking? Are we talking a huge amount of money to give the agency the kind of resources it needs? Are we talking about a reasonable amount? What's reasonable?
I think
depends upon
I would
your
build
viewpoint.
from the funding which CEPI has already used and look at this study to see what a business case would look like. I'm sure that's very much in the thoughts of the scientists who are currently looking at what an international or a local system might mean.
Thank you.
Well, just you said there in response to my lady's question that coronavirus was something that the scientists were already looking into. If it was something that they were already aware about, it was already on the horizon and were looking into, can you help us with why it was then only in July that that there was this retrospective review?
I would say that the priority was to create the standards and reference materials that our laboratory scientists are expert at. They supply over 90% of the standards worldwide, and these are the materials that enable testing, diagnostics to be accurate and reproducible and consistent. So that really was the first priority in mind. And as I mentioned a moment ago, only when it was clear that we could adapt the environmental surveillance was that piece of work done.
I've asked you about the limitations, and you've given us some practical limitations to wastewater testing with regards to grant and funding and resourcing. Can you help us, and obviously you need to know what you're looking for in order for there to be value with regards to wastewater testing. Can you help us with what the real benefits of wastewater testing can be?
It would, I think, enable early warning and monitoring variants. Those are the clear benefits if scaled up and adequately resourced. I think it's worth, perhaps if we do touch on the World Health Organization agreement of last week, thinking about the pathogen access and benefit sharing group that would, I think, now need to be the basis for the design of a system. And let's look forward to countries involved putting their scientists into this work.
You've mentioned the WHO agreement that's been recently reached. I think it was last week it was signed. We've got that available. I wonder if we could bring up INQ 587665, please. This is the WHO report, and if we go to page 13, a number of articles, it says there at the bottom of the page, I'm not quite sure why it's highlighted green, but it is, that's how it's been provided. Each party shall strengthen its national and, where appropriate, regional regulatory authority responsible for the authorisation and approval of pandemic-related health products, including through technical assistance from and cooperation with the World Health Organization. And I think if it goes over to the next page, and other international organisations, upon request and other parties as appropriate, with the aim of ensuring the quality, safety and efficacy of such products. So, in essence, what Article 8 it is dealing with here is to make available and to update information on regulatory processes for authorising the use of pandemic-related health products and to promote strong regulatory systems with international alignment where possible. And can you help us whether the agency is ready for this or taking steps to be ready towards this?
Well, absolutely. It happens to come at a time point when the agency, as in the statement, is already looking at changing, reforming the law on medical devices, and that includes diagnostics. But what we see here, and it's, I think, right through the agreement, is a focus on equitable access, which I think is part and parcel, as was said before, no one's safe till everyone's safe. And for that reason, the coming together to look at what an expedited pathway, like the emergency exceptional use authorisation might look like, what effective vigilance is like on an international scale, and reliance on decisions made by other regulators. So all about this, about being better prepared, but more agile in response, including equitable access.
That can be removed. I'd like to move on to ask you about the DHSC self-test. Now, the inquiry's heard evidence about the test already, and I'd like to focus on the agency's role with regard to this test. Now, for context, the agency provided DHSC with support to become a legal manufacturer of self-tests, also known as the lateral flow device tests. Is that right?
That's correct.
And Inova was manufacturer of the test, is that correct?
Yes.
And DHSC subcontracted the provision of the supply of the kits to Inova, is that so?
Yes.
And the agency seconded a member of staff to DHSC to support the efforts, including ensuring that instructions for those self-tests were fit for purpose. Is that right?
Yes, the goal was to integrate a good understanding of regulatory requirements and to be able to look at an application from the DHSC in the shortest time possible. There was very great care taken to ensure that the staff, the teams of scientists and clinicians who would look at the data were not involved in close advice to the department. So that separation was very fundamental.
Now, the agency granted an exceptional use authorisation on the 22nd of December 2020, is that correct?
Yes.
And that was because there was no CE marking. The CE marking that you've already referred to signifies that the medical device complies with EU legislation, is that right?
Yes, and there was no alternative product available CE marked.
And on the 10th of June 2021, the US Food and Drug Administration, the FDA, issued a safety notice and a recall letter with regard to those Innova LFD antigen tests. Is that right?
That's correct.
And if we can have up INQ 496261, we can see here, and I'll perhaps deal with it as briefly as possible. There were three reasons cited here that we can see. Firstly, the tests had been distributed in the US without the Food and Drug Administration approval. Secondly, the labelling included a clinical performance section which claimed a level of sensitivity and specificity that was not matched by the evidence that the FDA had seen at the time of the inspection. Thirdly, that there were significant failures in the quality management system in the company. And fourthly, it's dealt with in the section below that Innova did not notify DHSC of the FDA audit and findings. So I'd like to ask you about the second and the third of those matters, please. If we could turn to page 2. We can see here that the false negative results, which may lead to delayed diagnosis or inappropriate treatment, and false positive results that could lead to a delay in both the correct diagnosis and the initiation of an appropriate treatment. Can you help us understand whether the agency was satisfied with the information it received about the efficacy of these tests, in particular their sensitivity and specificity?
Yes, I can. And I think the first thing to say in this context is that the use in the UK for asymptomatic people feeling okay at home, was different from the use in the US. And what data were provided at the time of the application back in December 2020 assured us on the laboratory, analytical accuracy, and on field studies, and thirdly, usability. The question, of course, is always, in a regulator's mind, overall benefit and risk. And I'm sure, even with the prism of reflection back, we can all see what a change it meant to allow people, enable people to test at home rather than driving to a testing centre, and to have a result within 15 minutes or half an hour. So a benefit in enabling that change, big change to happen. Of course, the sensitivity of the test was very much in mind, and the fact that we've already heard, I think, from some witnesses about the debate about how infectiousness and being asymptomatic relates to amount of virus, the viral load in the body. So there were some uncertainties, but the judgment that resulted in the issue of the authorisation was that about 2/3 of cases would be identified and prevented, and chains of transmission could be broken such that there would be benefit at that time. So the reasons for the agency's decision, I think, were clear. Having said that, absolutely inherent in that decision was very clear mitigations and a very clear message to self-testers, to people using this test, is that a negative does not guarantee or mean that you do not have COVID. And that was always very clear. This was what we call a red light test, not a green light test.
Now, the inquiry's received evidence from Professor John Deeks, a medical statistician at the University of Birmingham. And he explains in his statement, I don't think we need to pull it up for time, but he had an official role within the agency between March 21 and July 21 as a member of the In Vitro Diagnostics Expert Advisory Group. And he gives reference to a letter that the group wrote on the 8th of July of 2021 to the Director of Devices at the agency. And we can see that, and I will ask that that is pulled up, INQ 531145, please. Thank you. We can see this is the letter that was sent. And if we go to page 2, for example, he sets out, the letter sets out a number of concerns and issues. So, for example, it says there at paragraph 1, we would advise that prior to any further extension of the authorisation of specialist use, the agency should seek independent evidence and not just rely on the evidence submitted by the manufacturer. Was this a concern that you recognised?
The agency always takes into account all available evidence at the time of reaching a position. But what's important about Professor Deek's letter and the In Vitro Diagnostic Expert Advisory Group is that we also have access to independent experts to, if you like, challenge our decisions. I think I could explain that at the time of the FDA letter and recall, we paused an extension and carefully considered at that time, which was mid-21, whether it was still justified, knowing that the company were preparing for a CE mark, and we were eagerly anticipating that they had done the work for that. The agency had also audited the company and was aware of areas that needed attention in their systems, which we may come to. So this, I think, accords with the view of the agency. Of course, the question then later in the letter is that the changed terms of the EUA did include one-off testing prior to an activity, which the expert advisory group had concerns about.
And that CE markings dealt with at paragraph 4, and at paragraph 3, the letter raises the independent scrutiny of the claim that the test has 95% sensitivity for infectious people. Can you help us with whether the Innova test achieved the lower limit of the 95% confidence interval above 60%?
I would have to check data available at that time to assure you on that. Although clearly we were monitoring, this is mid-June, work ongoing, for example, the Liverpool study.
And there were a number of reports, I needn't take you to any more, but a number of reports and concerns about the efficacy of the test, false positives, false negatives. Should the agency have been more robust in its scrutiny of the Innova and other test kits once approved, given the significant risk from inaccurate results?
I'd like to be very clear that the issuance of an exceptional use authorisation is really just the milestone. There is a very rigorous ongoing monitoring and a set of requirements, particularly around post-market performance follow-up, that, if you like, we're sitting on the company's tail or the legal responsible body's tail all the time, fortnightly updates in this case. So I would like to assure you that the approach of the agency is very rigorous and ongoing.
Can you help us with the agency was involved in assessing the swabs, for example, and can you help us with what consideration was given to those who were, for example, neurodivergent or healthcare workers with regard to using that method of testing? Was that within the regulator or the agency's thinking?
Yes, it was, and I know that our test team had a lot of ongoing interactions to make sure that the instructions for use were as helpful as possible, available in 11 languages, and also a video. So multiple modalities for people to understand, really quite an important and very clearly defined set of requirements there.
Did the agency have any role in regulating the Lighthouse laboratories?
The agency doesn't have a role in regulating laboratory practice. This is the UK Assessment Service, UCAS, that does this, and will leap in, though, if products are being used that are non-compliant, they don't meet the standards that would be expected under the legislation. And we didn't have any reports. Otherwise, we would have, as I say, jumped in.
Now, the inquiry's received some evidence in April of 2020, correspondence between the Catapult Medicines discovery and Deloitte with regard to voiding of test results caused by the use of supermarket sandwich bags. And we can see that at INQ 511040 at page 2. Can you help us with the agency's role with regard to collection of those samples?
Requirements in terms of the function of the medical device, in this case I think it is the PCR test, are clearly described. These laboratories were working under enormous pressure, and as I say, it isn't the MHRA's role to step in and regulate how their processes work. I'm assuming that the processes would have been evolving rather rapidly, and I think we've heard about Rosalind Franklin, for example, being state of the art. You know, that the digitalisation of these end-to-end processes has made a very big difference. I hope the comments are helpful, but in a nutshell, we wouldn't have had a responsibility for this.
And similarly, on the 13th of May 2020, if we can pull up INQ 511161, page 1, here there were concerns that were raised, voiding of samples because of faulty kit. So split tubes, 2 samples in the same tube, labels covering lids of tubes, samples with no liquid, and sample tubes not being sealed correctly. And then if we go to INQ 51111, page 1, there's reference here to unvalidated tubes. Can you help us with regard to the agency's role in swabs and sample collection tubes?
These are, as individual consumables, subject to the requirements of the medical device legislation and the regulations that we oversee and give guidance on. And depending on any signals we get, any harm that results, as I say, we would distinguish our role to ensure that products perform as appropriate and are safe. However, the issues around what happens in a laboratory, the standards that apply there, need to be looked at through the accreditation role.
And just finally, I'd like to ask you about the Randox tests. So sticking with that theme, the Randox tests at paragraph 176 of your statement, you explain that the National Testing Programme flagged them to the agency. Can you explain what the issue was that was raised with you?
The issue was that the regulation of this kind of product is a matter for the categorisation that allows for self-certification unless any part needs to be sterile. And in the case of these kits, the swabs needed to be sterile, as you can imagine. The worry about a contaminant either making the test invalid or causing patient harm. So the agency was very clear that there had to be microbiological or cultures done to test if there was contamination. The understanding shortly after that alert was given to the agency was that there had been communication to stop use. I believe that was on the 15th of July, and that had gone out on gov.uk. The reason for the recall later was that it became clear that the kits were still being used, and therefore they had to be removed until such times the swabs were sterile.
Thank you. That completes my time with you, Dame Rain. Thank you. I believe there are some core participant questions.
Certainly, I think Mr Thomas is first. Mr Thomas is over there.
Good afternoon, Dame June. Just a few questions. My name's Leslie Thomas and I'm representing FEMHO, that's the Federation of Ethnic Minority Healthcare Organisations.
Good afternoon.
Between the 3rd of March 2020 and the 30th of June 2022, the Medicines and Healthcare Products Regulatory Agency received 3,430 adverse incident reports through the Yellow Card scheme relating to devices using COVID-19 testing. These included reports of missing or defective kit components and possible incorrect results. And we note that all reports were triaged and assessed under normal safety surveillance processes. We would like to explore how this monitoring system functioned for healthcare workers, particularly those from ethnic minority backgrounds. So with that in mind, let me turn to my questions. Firstly, Dame June, can you assist us with what steps were taken to ensure that healthcare workers, including those from ethnic minority backgrounds, were aware that the Yellow Card scheme could be used to report concerns about COVID-19 diagnostic tests, such as the lateral flow and the PCR tests?
Well, thank you. It's a really good question. Many of the healthcare workers will have received messages about reporting for medicines, but in fact, the Yellow Card scheme took reports on medical devices, including diagnostics, since 2014, I believe. So they would have known that they could report. But the important point is that a COVID portal was set up by the May, and that was particularly to invite reports not just about medicines or vaccines, but about medical devices.
Were any of the 3,430 reports linked to patterns of concern raised by frontline health or care staff? And did the MHRA analyse this data in a way that captured occupational or demographic context, including ethnicity?
We do capture the reporter's specialty or profession, and that's really part of the analysis that's done. I am not aware that the scheme actually looks into the demographics, ethnicity and so forth of the reporter. We do that for the patient. So I think that's a gap you've highlighted, and I would like to look further into it.
Okay. What engagement took place with NHS bodies, professional associations or community health networks to promote participation in the scheme among healthcare workers from minority ethnic backgrounds?
I participated as someone from an executive agency of the Department of Health in multiple interactions, largely led, I believe, through NHS England, and my laser focus was on ensuring outreach on reporting. I mentioned, I think, in Module 4, as an example, working with Vaughan Gethin in Wales for this. But I did also stress that more can be done, and I think for the future, a planned approach will be really important.
Finally, this. In light of feedback that the scheme lacked transparency or trust among some groups, what changes would the MHRA now recommend to ensure that future safety reporting systems are inclusive, responsive, and actively used by those most at risk?
Thank you. This is a really important question and an important priority. I believe my legacy for the agency is a yellow card strategy that does include this kind of much more facilitated interaction, the ability for our what we call interactive drug or device analysis prints to be able to search out relevant information for the health professional who's interested in a particular safety issue is at the heart of that. And I think there will be a lot more that you will see as that important strategy moves forward. I think that's a key development and a key milestone in our reform of legislation for medical technology is coming into force of post-market surveillance requirements, which is the middle of June. So a lot is happening and more will be done.
Dame June, thank you.
Thank you, Mr. Thomas. Ms. Mirage is just there.
Thank you, my lady. Good afternoon, Dame June. I'm Thalia Mirage, and I ask questions on behalf of the COVID-bereaved Families for Justice UK. Two topics, if I may, starting with the yellow card reporting an online system of surveillance to which you were taken just now. And my lady, with your leave, if I could just tailor my question in light of the matters explored with Dame June, with Mr. Thomas. And it's this. You mentioned moving towards equitable access. And bearing in mind that the online reporting system, it was digital, it was online, would you agree that the exclusive use of online platforms for reporting lost, late, or incorrect test results potentially excluded sections of the populations, such as those, the elderly and the digitally excluded?
Thank you for your question. It's really important. The agency has kept alive different ways of reporting, and it's quite clear that someone can report on your behalf. So you just need to tell someone that you've got a concern or a worry, and your health professional or a member of the family can do that for you. But it's still possible to phone or to use a paper report, a card. So I hope that is of some reassurance, but digital exclusion, we do understand, is a very important issue.
And I think, my lady, that deals with the second question in terms of forward planning. Dame June, may I move to my next topic briefly, which is NHS Digital, which you touch on at paragraph 63 of your statement. In short, the MHRA software team worked with NHS Digital in the COVID-19 app in relation to the development of contact tracing and the lateral flow device reader. Knowing as we now know that there were, by the time the NHS app was rolled out, there were more than 3 symptoms which were known to detect COVID-positive symptoms. However, the app only captured fever, cough, and shortness of breath. Firstly, was the NHS app subject to the MHRA regulatory oversight and scrutiny?
The app needed to conform to the requirements as a medical device, yes.
So in light of the limitation at the rollout, the start of the rollout of just the 3 symptoms, was there regulatory oversight over the period of the life of the app in terms of data updates?
I'm very confident there will have been. I can't give you a date as of today as to when a change in taste or smell might have been added in there as a symptom, but the coherence of the different sources of information is a really important one, and the app was clearly very well used, as we heard earlier from the previous witness.
Right. It's just that during the life of the app, there were known to be more than the 3 symptoms. However, it was not updated. And so the question and the issue for you, if you can assist us, is whether the failure to pick up on the additional symptoms could be considered as a gap in the regulatory framework.
Well, those additional symptoms, as we know, COVID had different manifestations in different people. Really important point. I would be surprised if the app wasn't updated, but I stand corrected if you're able to speak with confidence on that one. It's something, consistency between information sources, really important. Otherwise, trust in experts, including government, isn't taken as read.
Thank you. My lady, that's as far as I will take that point in light of Dame June's answer.
Thank you very much indeed. Dame June, that completes the questions. I think it probably completes your assistance to the inquiry. So thank you very much indeed for all that you've done to help the inquiry, and of course your colleagues who've helped prepare the corporate statement.
And the agency as a whole, my lady, has been made an immense and outstanding effort in this time of crisis with results.
I'm really grateful to everybody, and may I wish you luck in your so-called retirement. I suspect it won't be a retirement if you're anything like me, but thank you very much.
I'm very grateful to you, my lady.
I shall return at 1:55.
All rise.